All right, so we're going to wait just another moment here until we get let some people get on. Some people are slowly trickling in, so we're going to wait just another moment here, and then we're going to get started. I'm going to wait 10 more seconds, then I'm just going to dive in. And people can catch it on the replay. So, all right, well, welcome everybody. We are very honored to have Dr. Archelle Georgiou here with us today. I'm going to introduce her in just a moment, but in these unprecedented times where there's no roadmap to know exactly what we should be doing and what where we're going to be ending up. So it's always good to have medical experts to help guide us in this journey. So I'm going to introduce Dr. Georgiou, and I hope I'm pronouncing that correct. Is that right, Dr. Georgiou?
No, whatever works for you.
Well, I will do the best I can here. So Dr. Archelle Georgiou is a nationally recognized physician, author, medical executive, and health reporter. She earned her medical degree from the Johns Hopkins University School of Medicine and served as a senior executive and the chief medical officer of United Health Group from 1995 to 2007. Dr. Georgiou is an adjunct faculty member and an executive in residence at the University of Minnesota Carlson School of Management. In addition, she maintains a diverse portfolio of advisory relationships with companies and organizations that improve health and the healthcare system. As a medical expert, she has covered over 1,200 medical topics during her weekly segments on KSTP-TV, which is the ABC affiliate in Minneapolis-St. Paul. Based on her interactions with viewers, Archelle developed the CARES model, which is a 5-step approach that consumers can use to make healthcare decisions. And in February 2017, she published her first book, Healthcare Choices: 5 Steps to Getting the 5 Steps to Getting the Medical Care You Want and Need. And if you want to look that up, again, that's Healthcare Choices: 5 Steps to Getting the Medical Care You Want and Need. And that's by Roman and Littlefield. Archelle is currently the Chief Health Officer for Starkey, and she just joined in February after the Starkey Expo. She's responsible for Starkey's commitment to improving individuals' overall wellness and quality of life through their products and better hearing. She maintains strategic relationships within the medical community, oversees the healthable features embedded in the company's hearing aids, and brings hearing health to the forefront of overall health. So, Archelle, who is trained and board certified in internal medicine, thank you so much for joining us today.
Thank you so much for having me.
So I'm going to dive into the very first question because I am not an infectious disease or I'm not a physician either. Can you tell us what is COVID-19 and what is coronavirus in general, please?
Absolutely. Well, COVID-19 or SARS-CoV-2, which is the official name of the virus that causes COVID-19, is in the family of coronaviruses. So this is a family of viruses that we are very familiar with because they cause the common cold. And there are a total of 7 known coronaviruses. 4 of them cause the common cold. And then there's SARS and MERS, which we're familiar with, and they caused more serious disease. And of course, we also have SARS-CoV-2, which causes COVID-19. And just because I always love the why and the science. So the coronaviruses are called that because they have these spike proteins on the outside of the virus, which actually become very important in how they attach to the human body. And these spike proteins are critical to how the COVID-19 virus actually is such a, ravages the human body. So it's, but they're in this larger family. And of course, the viruses that cause the common cold don't do as much damage as the ones that we're experiencing right now.
Right. And how does it spread? I mean, people are talking about, it goes it can be what's it called? Sorry. Thank you. Yes, it can go that way. It can go hand to hand. How does it spread?
Well, what we know is that that COVID-19, and I'm just going to refer to it as COVID-19 as opposed to SARS-CoV-2, that it is spread through respiratory droplets. And so it goes into the respiratory tract, and the proteins on the outside of the virus actually are attracted to a particular receptor in the lungs, deep in the lungs, and that's called the ACE2 receptor. And so it attaches there. And so we know that respiratory droplets are the primary route of transmission, but we think that it also could be aerosolized, and that's why we're seeing a lot more ramping up of, for example, on Friday, there was a recommendation that Americans, when they go into places where there would be other people, that they would wear masks. And it's because we're believing more and more that there's also a possibility of transmission through aerosolization. But you can't like swallow it. Like, so if you eat fruit or food with it on it, it's not ingested. There is some maybe fecal transfer, but it's probably not a primary route.
So with the pulmonary side of it, so when people are sneezing, we've been talking about 6 feet for social distancing, but there was a study that was out, I think it was last week or earlier this week, where they talked about when somebody sneezes, it can travel up to 27 feet. What are your thoughts about that?
Well, everything that I've heard is about 6 feet. And so whether you cough or you sneeze, or you even clear your throat, the distance that's been measured for the larger droplets and some of the smaller droplets is about 6 feet. So that's where the social distancing guidelines come in. But if in fact it's aerosolized, then there's a much larger circumference of space where that aerosol could be, where the aerosolized particles could be. And that's probably where the 27 feet is coming in. I haven't heard that specific number, but I'm assuming that that's where it comes from.
Yeah. So, there's people are wearing masks everywhere now. There's a time frame, right? In terms of how long you have to be exposed to it before it can actually cause harm, or is it more instantaneous?
There's so much that we don't know. I'll tell you what we know today, and tomorrow it could be different. So I apologize for that in advance. But what we believe is, to repeat that question one more time, I want to make sure that I answer it specifically.
Yeah, and maybe I can rephrase it. So there's, I think I was listening on your ABC segment, I think it was last week maybe, where we were talking about people, or you were talking about people that were just walking by. And
that's right.
That time frame between walking by somebody versus being around somebody for a longer time.
Yep. Yes. So there are different levels of exposure that create risk, and there are many different combinations and permutations. But I found the simplest explanation to come from the European CDC, and that's what I shared online that you probably saw. And what they said is that a low risk exposure is less than 15 minutes as long as you're still 6 feet away. And so, they just can't create scenarios for what's low risk, medium, high risk for every single social interaction that there could be. So, but when people want to think about, is this a high risk? Is this a low risk situation? Think about 15 minutes over that being high risk, and 6 feet, closer being a little more high risk, farther away being lower risk. So those are the two parameters to think about.
Yep. What about, so should we be wearing masks and gloves everywhere we go?
So there's a lot of chaos, as you know, around COVID-19. And I have really stuck to the rule that I'm going to follow the guidelines, because there's a lot of smart people in Washington and Atlanta who are making decisions and giving guidance. And we don't need one more doctor giving more guidance. So I'm going to stick with the CDC guidance. And as of Friday, the recommendation is that all of us, when we are in spaces where there's other people, not in our homes, but when you go to the grocery store, if you think you're going to be in an environment where even if you're trying to maintain a social distance, there's other people, that we wear cloth masks. And I think they were very careful to state cloth masks, because we want to make sure that we preserve the surgical masks and the N95 masks for the healthcare workers and those who are in more serious healthcare environments to need it. So as of Friday, that is the recommendation. So there's always a gray zone. I was out walking, taking a lovely walk with my family earlier today, and we all elected to not wear masks because we were outside. But if I went to the grocery store, I would wear a mask.
Would you wear gloves at a grocery store?
Um, I would either wear gloves or I would definitely take a pack of disinfectant wipes and be quite careful. Yeah.
Yeah, no, that's good. That's good.
Yeah.
We work with patients, and of course, when we want to practice social distancing and being, 6 feet away from them, sometimes it's hard to do. So, we're wearing masks and gloves with every patient, and then discarding those PPEs. What is your recommendation that what are the things we can do to protect ourselves and our patients in our practices?
Well, I think the first thing to think about is uh, really rethinking how you interact with patients altogether. And so there are probably a number of interactions that could be completely converted to a telehealth interaction. And so, depending on which manufacturers devices you use, I'm not familiar with all of the manufacturers, of course,
Sure.
but I know that Starkey in particular has many different options for remote programming. And then so I would absolutely, for everyone, just think first, is there a way for me to interact and meet the needs of this patient through a non-face-to-face interaction so that we can maintain as much safety as we can? And what can you do through telehealth? There are certainly going to be circumstances where they need more than that. They need some other level of interaction. And then I would go to the next level of, can you do a curbside transfer of device or transfer of batteries or service or whatever the case may be? And then there's going to be a smaller subset that have to come into your office. And in that group, with that group of individuals, making sure that you're not working when you're sick, of course, and your staff isn't, and making sure that you screen the patients who you would potentially be coming face to face with to make sure that they're not getting exposed to you, and that you're not creating risk for each other. So go ahead.
No, please.
So in that environment where you are face to face, you're in their office and you've already made sure that you've pre-screened them to make sure that they're not sick. Using all of the guidelines around social distancing and gloves, if necessary, even a face shield if you're getting really way too close, to make sure that you're protecting yourself and them.
Got it. So when you talk about the high risk, so we've read about folks that have diabetes or pulmonary issues. What is it about diabetes that makes those folks or those patients with diabetes a higher risk?
So the theory is that diabetics have some level of their immune system isn't going to react like a person who doesn't have diabetes. And so it's that early immune reaction that we really depend on to clear the virus. So a difference between people who feel like they may have a cold or maybe some flu-like symptoms with COVID-19 versus those who end up in the hospital and get really sick has a lot to do with how the early response of the immune system. Diabetics are compromised by that to some extent.
Mm-hmm.
The second possible reason that's really being debated a lot this week is whether or not many diabetics are on a medication that actually increases their risk. So maybe it's not the diabetes itself, but maybe it's the medication that many diabetics are on. Also a medication that a lot of people with heart disease and high blood pressure are on. So those are the ACE inhibitors. They're the ones that end in pril, like captopril, and then people who are on angiotensin receptor blockers, ARBs. So that's like losartan, and they tend to end in sartan. So right. It's possible that another reason why people with diabetes are higher risk is that so many of them are on these medications that increase the number of receptors that the virus is attracted to. So they become more of a target for that virus. We don't know, but that's another possibility as well.
Yeah. So I don't feel any of the symptoms. I don't have a fever. I don't have a dry cough. I'm not feeling any of the symptoms. Should I get tested for COVID-19?
Absolutely not. So, and even if you, at this point, at this stage in the country, now there may be some states that have ample supply of testing, but many, and I'm not sure that even California has ample. You're in California. I don't know that any state can say that they have ample supply of testing. So the recommendations today are that if you have symptoms of COVID-19, and we can talk about what the symptoms are, but you're not sick enough to end up in an emergency room. So basically you don't have shortness of breath, then treat it at home, assume that you have it, quarantine yourself, stay quarantined for 7 days minimum, plus at least 3 days after last having a fever that you don't have to treat. And that's what the treatment would be at this time. So we just don't have enough testing around the country to be able to treat somebody who's totally asymptomatic, or even those who are symptomatic but not sick enough to get hospitalized.
Right. Okay. What about so the biggest research in terms of treatment, and maybe it's not the most accurate, but at least the most common talked about research has been about chloroquine and hydroxychloroquine,
right,
with azithromycin or Z-Pak. And then there's some studies from Japan that have some antivirals, and then Italy is showing some stuff. What's the latest on that treatment curve?
So it's continuing to emerge, and there's 4 decent studies that are out, and none of them are great. They're all pretty small, and there's only one that's been controlled. So hydroxychloroquine, for anyone who's not familiar, is it's a very old drug. It's been used for many, many years to prevent and or treat malaria. It's also very commonly used because it's an anti-inflammatory to treat people with lupus and rheumatoid arthritis. And so that medication, in combination with a Z-Pak, azithromycin, has been shown to have a synergistic positive effect on at least in these very small studies of patients that have COVID-19. So there have been 3 studies. There's a total of 4 studies. 2 of the first studies, both not controlled, showed that people that had the combination drugs cleared the virus more quickly than people that either had hydroxychloroquine alone or had nothing. So that looked really quite promising. There was one study out of China that showed there was no difference at all, just FYI on that. And then there was a 4th study just published earlier this week that was controlled. So that was promising. It was a little larger. And the difference in that is that they treated patients in the early without such severe symptoms. So they had pneumonia, but they weren't ventilated. And so it seemed to have a really positive effect on them as well. So it's directionally positive, but it certainly isn't the kind of data and science to say, yep, we've got the treatment for this. Still a lot of science to do. That being said, last Sunday, the Food and Drug Administration did create a new emergency indication for hydroxychloroquine for the treatment of COVID-19. And, frankly, it was being used anyway around the country because it's just an off-label use, but that allowed them to put more drug into the federal stockpile.
Yeah, I think I remember hearing that most of the physicians who are working in New York have already started taking chloroquine. What about sunlight? So here in LA, we love our sunlight. There's some data about sunlight or even heat. And when this first started, there were a lot of talks about, in the summer we're going to be good because the heat's going to kill this virus. What do you know about sunlight or heat?
So summertime and the concept of heat are 2 different issues. So we can talk about both.
Yeah.
So the concept of heat has been somewhat of a myth. And it was disappointing to see actually the CEO of a very large fitness chain advise all of their members that they should try to get their core body temperature up because heat can kill this virus. That's a myth. Heat does kill this virus, but at 132 degrees. So that's not compatible with life. And at 132 degrees, like if you boil it, it will unravel that S protein and it denatures the protein and it kills the virus. So yes, heat kills it, but not heat that is compatible with human life. So let's take that myth off the table. Now let's talk about summertime. And many viruses have seasonality. There's some viruses that like the cold, dry weather, like influenza,
Mhm.
and there are other viruses that like the warmer, moister environments. And so it's not unusual for many different viruses to have seasonality. And so there is a possibility that we're going to see, hopefully, that this virus slows down as we get into the warmer summer months. But, you know, we shouldn't count on that, because the issue with this virus is that it was initially called the novel coronavirus, the novel new, because none of our immune systems have seen it before. So none of us have had immunity. We count on that seasonality when a portion of the population has some natural immunity. That's not what's going to really change the curve for us. We're going to see a little bit of effect, but what's going to change the curve for us is social distancing.
Yeah, and the neat thing about social distancing is it's also reduced the number of influenza cases
Yes. I don't know that it's done that, but I will tell you what it's done. There was a doctor from Duke who was tweeting, and then one from Michigan who was saying that in the period of time that social distancing has been occurring, and doctors and hospital personnel have been incessantly washing their hands way more than they did before, they haven't seen any cases of C. difficile in their hospitals. So there's some wonderful unintended consequences of all of this.
Right, silver linings, right?
Right.
We'll take it when we can. So I'm a fairly optimistic person, and I know based on the research, and we're seeing all these curves, and there are people that are posting graphs. Every day we see something different, and I know that we're getting closer. We're not there yet, of course. We're getting closer to a peak, and hopefully over the next few weeks, and hopefully not months, we're on the downside of this of the curve itself. And as long as we continue social distancing and great hygiene, do you feel confident that we're going to see this sooner than later?
Well, I think it all depends on what the definition of sooner is.
Yes.
And that depends on how, as a nation, we really come together to try to flatten this curve. And there's many different models out there. Like every state has multiple models that they're working with. So there must be hundreds. Mm-hmm. And I will just share a very simplistic view of probably what some models are taking into account, and which is going to be directionally correct. So if you take, the only reliable data point that we have across the world is the number of deaths, mm-hmm. Because the number of cases really depends on what the testing capabilities have been in every nation. And even in our own United States, we don't know how many hospitalizations there are. I mean, there's no reliable data metric except deaths. So let's start with deaths. And if you look at China, which is where we've, clearly seen the curve go down in the other direction, fortunately, and we look at the first death that China reported, it was January 21st. Mm-hmm. And then they had a huge peak, and then it took them exactly 70 days to get to the point where they had less than 10 deaths per day. So let's just, from the first death to a peak and then to less than 10 deaths a day. Our first death in the United States was March 1st, and that 70 days takes us to the middle of May. Mm. Now that compares us to China, which had many, just a very different social structure, very different level of adherence to social distancing. So I think that's optimistic, is middle of May. I think it would be interesting, I haven't done this myself, but to look at how long it's going to take Italy to flatten out, to get to less than 10 deaths a day, because our behaviors culturally, the testing issues, et cetera, much more aligned with what Italy looks like rather than China. Yeah. So I would say middle of May to middle of June.
Okay.
Is that sooner rather than later?
That's sooner. That's soon. That's soon. Soon is good. Anything soon is good, I think.
Okay.
Where can people find, or where do you recommend people get the best reliable information about COVID-19?
Oh my goodness, we're all being so bombarded with data, and there are many good sites out there. But if I would recommend one site where I think it's updated many times a day and has a comprehensive amount of information on it. And it's Our World in Data, all one word, .org/coronavirus. So it's Our World in Data slash ourworldindata.org/coronavirus. And the reason I like it so much is that it's all data driven, but that data isn't just thrown at you as, like, here's all the data, interpret it. They actually help you interpret it in a question and answer format. And then if you like, because they always give you a global view, but then if you like, you can slice and dice all that data with a very easy user interface.
Mhm.
So that, like, for example, when I shared with you that China had its first death on January 21st. It was from that site. I was able to take every single data point and then compare it to the United States. So really easy to use. And certainly, the World Health Organization and CDC and so many other sites are excellent. But this one, I think, is well done. Well done.
Yeah, I put the website right on the screen there. So anybody who wants to go visit that site, you can go to ourworldindata.org/coronavirus. I know that on AB, this is totally off the top of my head here, but when you're on ABC, you like to do a positive kind of ending on all your segments. If you have something available right now in terms of a positive ending, please share. If not, we will summarize and go to Q&A.
Sure, happy to. Well, there's two things. One I did share yesterday, and I think it's still good news today, and it's that I was looking at the curves for Spain, France, and Italy, and a picture tells 1,000 words. And so you can see from the curves of the deaths in those countries who've suffered so much over the last several weeks that they've crested and they have had that apex, and they're just starting to come on the other side of that. And so my heart just feels so happy for them that they're starting to see light at the end of the tunnel. So good news in France, Italy, and Spain. I'm looking forward to when our country can say the same thing. And then the other positive thing I'll say, since I'm from Minnesota, so I'm going to give a Minnesota shout out, is that our own Mayo Clinic on Monday is starting to do testing on antibody testing so that we can identify those individuals who have been exposed, who have antibodies, and might be somewhat more protected from the risks of COVID-19. And so hopefully that'll initially roll out to healthcare workers and then hopefully to a broader portion of the population. So I think that's everyone has really raced to the solutions here, and we've seen innovation like we've never seen before. And I think our world is going to be different than we've ever known it when we get through this.
Yeah, and hopefully for the better, of course. And I know we were talking before we started that here in Los Angeles, we're seeing less and less people outside, but there's still people outside. But we're hoping they're going to their essential work places. This morning we had a 5K, and I went down to the beach by myself, and I had my mask on, and I was just pulling up to the beach, got my stuff out, and then one of the security, I think he was a police officer, but had asked me to not be in the park, so I gathered my stuff and left. But that's good. They're monitoring that situation here in Los Angeles. So that is good news, and thank you so much for doing this. So we wanted to open it up for some Q&A, and we can go 5-10 minutes, and if there are no more questions, then we'll end it. But I'm going to see if there was one question up here which didn't come through as well. And let me see, there were some corrections in the post. So can you, and I'm going to clear this up for you. Can you see that on the screen there, Archelle?
I'm seeing them now, yeah.
So she asked, can you ask how much risk is there with, and she meant to say cerumen, not verumen. So my computer always autocorrects to cerumen. I don't know. Cerumen flaming skin. I don't know what that is. Dry flaky skin. There it is. So let me fix this. So can you ask how much risk is there with cerumen, dry flaky skin, etc., which we might come into contact with on hearing aids?
So I haven't seen any studies on cerumen, to be honest. So now I'm just using my knowledge of how the virus is transmitted and causes disease to answer the question. So the risk with cerumen, first of all, it is when you come into physical contact with it and then you your contact, your hands, then you get near your face. And so the risk with cerumen, I think, would be greater if you're not using precautions, using gloves, using a mask, etc. And so that's sort of just using my knowledge to make an assumption, but I haven't seen any studies that have looked at that specifically. But since we don't know, so important that when you are removing the cerumen that you have all that protective gear in place.
Yeah, hopefully we're not touching those hearing aids and touching our faces anyways, which would be gross. So that's a very good point. And I think maybe something that if anybody was going to look into it is, we know cerumen does have some antibacterial or antifungal properties, but you're absolutely correct that, just avoiding the face. That's a great answer. Let's see, there's this one here. Will they be testing patients who have recovered in an attempt to develop an effective vaccine?
Well, they're already starting. Actually, University of Minnesota again is in the lead for. They put a national study in place, but based out of Minnesota, to begin to develop a vaccine, and so that's being done in people who have not been exposed to the virus at all. But then there are individuals that have recovered, that they're going to be testing with this antibody testing so that they can confirm the recovery and then begin to understand how long we maintain immunity. That's a really big question. We know that our immune systems develop the immunoglobulins, the IgG, that can protect us, but we don't know how long they last. And so that's a really big question. So we're going to hopefully, there will be studies of people who've recovered to understand how long their bodies are protecting them with some natural immunity.
Very nice. Here's one from another audiologist here in Southern California. I think I know her fairly well. She actually works with me. Living in California near the beach, there has been some information in the media about salt water and salt air making it easier to inhale the virus. They are recommending no surfing. Beaches are closed, but surfers generally don't listen to warnings like that. Have you heard of this warning?
Wow, I have not heard of this warning at all. I mean, we're sort of landlocked here in Minnesota, other than the fact that we have 10,000 lakes. But that would assume that this is an aerosolized virus, and that's a mode of transmission. So I have not heard that. I would really check the sources on that and just make sure it's valid, particularly if you're a surfer and it's interrupting your quality of life. I just have not heard that.
Okay. This question comes from Sherry. What permanent changes do you think we will see from this? And I'm not sure if that's regarding physical changes or I don't know.
I think we're going to see awesome changes. I mean, I see the world through rose-colored lenses. So I think that there's some things that are moving forward that we're never going to go back from. So one, CMS has really opened up the gateway for using much more telehealth. And, we've been waiting for telehealth for 20 years, my entire medical career, and in managed care, we've been waiting for telehealth. The technology's been there. The reimbursement methodology has not from CMS. That's been the biggest barrier. They've opened that up now. I don't think that they're going to go backwards. And I think that's amazing. I think that's a really positive change. I think what goes along with expanding telehealth guidelines is the fact that you have to allow clinical personnel, and in this case, physicians, to operate across state lines. Otherwise, telehealth is really complicated to administer. And so they've introduced, in an emergency basis, the opportunity for physicians to practice in other states than when they're licensed. I don't think that that's going to be as immediate a change, because we are the country that we are with state licensing, but I think it's going to open the door to those conversations. So I think there's some really positive changes that are going to come from the tragedy that we've seen, and hopefully we can find those positive outcomes. And what I'm really hoping for is socially that we recognize that there are ways to interact without our phones all the time, and we really find creative ways to face-to-face interact with each other. So using amazing technology and our phones, but to be so much more personal than how impersonal we've been for way too long. So I'm looking forward to seeing how we interact with each other differently after this. I just last, I'm just going to be personal for a moment. Just last night, my mom is 88, and she's in Baltimore, and she's lonely, and I just love to make sure that I do what I can to keep her from being lonely, but I always just call her. And last night I invited her to have cocktails with me. So we had FaceTime, and she got her little cocktail, and I had my glass of wine, and I thought, why haven't I ever done this before? Right?
Yeah.
Why, call your mom, have cocktails with her mom, do that on FaceTime.
It's pretty amazing how many Zoom happy hours we've been a part of, and we don't need to go out. We can just sit here in our pajamas and enjoy ourselves.
Yeah.
One point about the state licensure, there's actually it's called I forgot the appropriate name, but it's a licensure compact, and it's going to be across all 50 states where one license can cross state lines for audiology. So that'll be a very interesting thing to see if that ends up.
Keep tracking that. That's important.
That is, absolutely. Let's see. Okay, Gail Brenner, she asks, what about secondhand smoke? Do you know about transmission that way?
Don't know about transmission through secondhand smoke, but I can talk about smoke and smoking. So let's just back up for a moment. Italy has had just the highest mortality rate in the entire world, and there's a lot of questions why. It could be that their rollout of testing was just delayed and it got out of control. There could be sort of a genetic component to the Italian population that made them hyper-react to this virus. But it could also be, a combination of these factors, but it could also be that the prevalence of smoking is so high. We do know that smoke increases the number of those ACE2 receptors. This always comes up. It always goes back to that darn ACE2 receptor. Yeah. Smoke increases the number of ACE2 receptors on the alveolar cells, on the lung air sacs. And so whether it's primary smoke or secondary smoke, it could increase the number of receptors, which makes an individual a greater target for the virus. So I don't know that the virus is transmitted through the secondhand smoke, but the secondhand smoke or the nicotine could increase the risk of an individual.
Speaking of the ACE receptors, ACE2 inhibitors, when people are taking those drugs, what is the prevalence of this?
Yeah, so lots of controversy, as I mentioned earlier, about that. It's possible the jury's out. We just don't know whether the ACE2 inhibitors. So ACE2 inhibitors upregulate ACE2 receptors. They're different. So when you're taking an ACE inhibitor, we do know that you develop more ACE2 receptors. But there's a big controversy going on as to whether that puts you more at risk or less at risk, whether it's protective against COVID-19. And so big cardiology debates going on at the moment. And the current recommendation is the following. It's that we don't know. And for individuals that are on an ACE inhibitor, it's controlling their blood pressure, don't stop taking anything that you're taking, because we do know that stroke from uncontrolled high blood pressure is fatal, or certainly could cause a lot of permanent damage. And so the current recommendation worldwide from cardiologists is it's possible that these medications could put you at higher risk, but since we don't know, stay what you're on, talk with your doctor. I don't know that doctors are putting people on ACE inhibitors right now, but they're certainly not taking them off.
Yeah, I'm gonna skip one question real quick, and we'll come back to it. But there's Natalie, our friend Natalie in Colorado. Dr. Phillips said a fellow audiologist posted today about her husband being in the hospital with COVID-19, and they are just giving him Tylenol and some oxygen. What would be things we could have around the house to help with watching symptoms? Does a pulse oximeter help?
I'm just going to reread the question again. COVID-19. So they're treating, the way I'm reading this is he's hospitalized. He's being treated with O2 and Tylenol. So good news is he's not very sick because he's not in the ICU and needing a ventilator. So when, I'm assuming the question is when that individual is discharged to help watching his symptoms. And so hopefully he'll be at a stable point and on the other side of this condition when he's discharged. But, pulse oximeters might be a good idea to just make sure that he's maintaining his oxygen saturation at home. And so a pulse oximeter could help if somebody is developing more symptoms, and you know what their baseline is, and so if they fall below their baseline, it might be an indicator that you might want to follow up and see if something's getting worse as opposed to getting better. But somebody asked me this question before: should people who don't have any symptoms at all, don't have COVID-19 at all, should they be using a pulse oximeter at home? And my response to that is probably not. We need to be treating patients, not numbers on a pulse ox. So if you have symptoms, if you are short of breath, if you have a fever, if you have a dry cough, those are the things to pay attention to, and call your doctor and have a holistic assessment about whether or not you need further care, further attention, as opposed to measuring a pulse ox number and saying, where am I on that scale?
Right. Very good. What about people taking normal antiviral medicine? Could they help decrease the spread and effect?
So I'll take I'm wondering that probably as somebody asking about Tamiflu, which is what doctors prescribe for influenza, and it's quite effective for influenza. Not effective, doesn't affect COVID-19 at all. So Tamiflu was a medication designed very specifically it's sort of like a lock and key, like a structure. It was only made for influenza, and it only works for influenza, and so doesn't work for COVID-19. So Tamiflu helps with flu, not with COVID-19. Got it.
Very good. I think we're just about out of time here, and I think there was another question here which was answered earlier. So I know why you're in such high demand, and really appreciate you taking the time. And obviously ABC and Minneapolis is very lucky to have you. And same with Stark. I think you're a fantastic asset for them. Thank you so much, folks. I'm going to I will upload this up on YouTube. I think the live will replay on Facebook itself if you click on it. If there are any other questions, you can post them, but I don't know if we'll be able to answer them at this point. So, Dr. Georgiou, thank you so much for taking the time. I'm going to do this because we're not going to shake hands or fist bump or anything, or do the foot tapping. And thank you so much.
Thank you so much. Really delighted to do it.
Okay, take care, guys. Be safe.